Good evening, and welcome to the 7th lecture series from ASHA. ASHA stands for Accept, Support, Help Another, and we are a support group dedicated to assisting doctors in India understand and manage their professional stress. So we hope to foster open discussions around this narrative and around professional stress within the medical community, because we believe that there isn't enough of discussions around this, and hence the issue tends to be very often brushed under the carpet, which itself leads to barriers to seeking help. And we know that amongst Indian doctors, only 1 in 10, if they are asked a question, do you have a doctor that you can approach if you have a physical or a mental health condition, only 1 in 10 will say yes to that question. We hope by this group, through this group, and through these lecture series, to increase that narrative, and also to help people understand ways of dealing with their own stress, and to use self-help techniques or to seek help from supportive others. To this end, we have a website, the link to which I will put into the chat. It's called ashafordoctors.com. We have a Facebook page. We have a WhatsApp group where there are regular chats. We have about 350 members now in that particular WhatsApp chat. We have a YouTube channel where most of these lectures are uploaded. And we started this discussion series of lectures, and we are in the 7th one. And I'm happy to see Dr. Ananta Dave here, who actually delivered our first lecture. ASHA is a body that functions in India, and we have an ASHA UK branch as well. And I can see Manoj and Ananta were part of the UK branch. And that's a very fledgling branch at the moment. Over the next year, we hope to come out with more programs, specifically to look at what are the barriers to help seeking amongst doctors, and also to look at what might stop doctors from actually accessing help and what would help them to access help. We also hope to look at what methods we could use to address the barriers to help seeking. So with these few words, I'd like to welcome all of you to this evening's lecture. And we have a senior pediatrician, Dr. Jayaraman, TP Jayaraman. And I would like to ask Dr. Alfred Samuel to introduce Dr. Jayaraman. Alfred, you're on mute, please.
Okay, sorry. Thank you, Dr. Arun, for entrusting me this pleasant duty of introducing my good friend, batchmate of Dr. Arun, Ashoka, Saumini, etc., who are in here, 21st batch of Calicut Medical College. Dr. Jayaraman Trikkovil Pisharam. He completed his MBBS from Government Medical College, Calicut, and later DCH and MD in 1991 from Institute of Child Health, Madras. joined government service, and later he left government service. And since then, he is doing private practice. He has completed 42 years of private practice now, practice in pediatrics. He was instrumental in setting up first neonatal ICU in Tangam Hospital at Palakkad. Started a center dedicated to treat the children with scholastic backwardness. And later he was responsible for starting an NGO, Changadi, which is actively involved in prevention of adolescent suicide. At present, he is working as a consultant at Dane Diagnostics and Palana Institute of Medical Science, Palakkad. He was the president of Indian Academy of Pediatrics in Kerala 2001 and president of National Neonatology Forum Kerala 2023 and 2024. Received Professor M.K.C. Nair Oration in Adolescent Pediatrics by Adolescent Health Academy Kerala State in 2022. He is happily married to Dr. Gauri, pathologist, and one son, Rohit, he is a lawyer. With these few words, I present Dr. Jayaraman TP. Thank you.
Thank you, Dr. Arun and Dr. Alfi for that introduction, that nice words. Actually, when Dr. Arun asked me a few days back to talk on an issue on professional stress from a pediatrician's point of view, I was little, something which I have never dealt before, and even though I had been a pediatrician for all these years, I have never thought of talking about it in an audience. And at the outset, I want to thank Dr. Arun and office bearers of this organization, ASHA, for giving me this opportunity to be here with this topic, as well as I congratulate you for trying to address a very important issue from a professional point of view. So with these few words, I thought I'll go to the topic. Actually, I was thinking what I should talk. Then I thought, I had been in pediatrics, as Dr. Alfred was telling. I entered pediatrics only because I was very passionate about that specialty. And I have not done anything in medicine other than pediatrics. Just after my house agency, within 1 week, I entered the field of pediatrics. And I have come through so many stressful situations. And I thought I will share my feelings, my experience with all of you, with which I feel with every pediatrician would have come across the same situations in their practice. I don't know how many pediatricians are there in the audience. I am seeing Sajivan. Nobody else I was able to pick up. Anyhow, I think every pediatrician will agree they might have come with these problems in their practice throughout these years. So, pediatric practice is every profession comes with a lot of stress, and doctors in general are having a lot of stress because people especially in India, the expectation of the public is more than what we can, and we are working in a compromised situation. Very often we are worried about the outcome of our work, and a child is always a weakness for the society. Every human being is sensitive about children, and so our practice being centered around in children, it is more stressful. There are a lot of studies in the literature I could find regarding stress, professional stress among pediatricians and physicians. And I was surprised to see that almost there is an increased incidence of more than at least 20 to 40% of stress among pediatricians all over the world, it seems, So maybe because there are various factors which are contributing to it, especially the very sensitive issue that everyone is very emotional when you talk about children, as well as when something happens to the children. The entire family, the parents' family the neighborhood, everybody is very concerned about these children in our society. And the parental reaction to every situation is different. What you see, what you find is not an emergency, maybe an emergency for a parent. And when you are not, so you have to cope up with different situations in your practice. And when I entered for my clinical life, that is during our third year when I entered the clinical classes, I was under Dr. Professor CBC Warrior, and he used to tell us that pediatricians are like veterinarians. And from that day, I was a bit scared about pediatrics, taking up pediatrics. Then it was during my internship when I was able to work under the great teacher, Dr. K.C. Rajagopal. I found out that my passion is there and I cannot be anything other than pediatrician. That's how I landed up in pediatrics. And as told, inspection is the only tool which I have in my armamentarium as a clinical tool when it comes to my practice, because history is not reliable, all the gadgets are not reliable, and I depend mainly on my clinical, my observation and clinic inspection is my important armamentarium in my practice. I think I'm not able to move it well. Okay. These are the common stresses we find. I will try to narrate a few stresses which are peculiar to pediatrics, and then try to find out what are some coping mechanism which I have found during my practice. That's what I am planning. Common stressors in pediatrics, one of most common is managing anxious or emotional parents, because we are not able to predict what is going to be the reaction. And again, our own emotions, because we are also human beings and we are very close. At times we are very much touched with the plight of a child who I am treating. A death of a patient is often very stressful for pediatricians, because we are all we also are very sensitive when it comes to a child. And again, another issue is when we are performing a procedure, what the colleagues expect from us. That is also a major stressful factor when you are in a senior's seat. And again, so much we depend on laboratory, and the laboratory personnel wants a very good amount of sample. This gives a lot of stress to us. You imagine a tiny with 560 grams or 500 grams, and we have to give about 2 or 3 ml or 5 ml sample the lab requires. Now we have got, of course, better analysis which can manage with lesser volume of blood, but it becomes an important problem for a major stress for us, especially when we are waiting in neonatal nursery. And how to draw the blood, that itself is a big strain. Again, you imagine doing an LP in a newborn baby, and later it becomes traumatic where we cannot come to any conclusion regarding the diagnosis. These are very stressful areas in our practice. And another situation is any child coming to you can become a serious problem or an emergency at any time. So child may not wait, I still remember my professor telling the day when I joined pediatrics in 1983, he told there are so many specialties in the world, If you are not prepared to see a child at 12 midnight, please don't join pediatrics. There are better specialties in the world, So that is because, and he added, these children die like flies. They may not wait for you till morning. So this is a very important problem in pediatrics, and every child has to be treated as an emergency, which may disrupt you, but it can be an emergency at any time, and they recover very fast. That sense of relief when a child recovers is also something which is great about pediatrics. And again, it is another important stress which I have experienced is in difficulty of breaking the bad news, especially to parents. And again, it's a moment of helplessness. You imagine a child with a spina bifida or myelomeningocele. Those days when spinal surgery and all were not very developed, the only treatment we used to do is to leave the child alone. Our Professor K.K. Verma used to tell, don't touch any child with myelomeningocele. They were left to die, to be very frank, So it was very difficult to convey these helpless moments to the patient, and it is so stressful. I still remember a child with Edwards syndrome, which is not usually compatible, but I had to keep it in my nursery for about 30-35 days till the child dies. So these are stressful situations when I know where I'm pushed to the wall and I cannot do anything. Still, I have to treat the baby and I have to convey to the parents. This used to be a big stress for me. Then failure, of course, when we are treating a child, a difficult intubation in a critically ill newborn, especially during resuscitation, and difficulties in securing an IV line in a preemie. When I can put an arterial line, I find it difficult. These are all stressful moments, and this procedure itself induces a lot of stress to a pediatrician. Then another situations which come across very common is milk aspiration cases, especially in places like Palghat, remote rural areas. It's a babies lie down after a good breastfeed and morning the mother is seeing the child is not alive. This is a very common situation we are facing, and they bring the child dead. This has happened even to my sister working in the ICU. She brought her child at 6 o'clock in the morning, dead following an aspiration. So these situations used to give a lot of stress to us during my practice. Then accidental deaths and injuries due to ignorance. You imagine a child fell into the pot of water when peeping into the bucket, which is kept to wash their legs. Just Kerala has got a practice of putting water in front of the house. For the guests to enter, they have to keep the feet and then enter. And I had an incident when a child who is staying close to my hospital was brought dead. The 2-year-old child accidentally fell into the bucket where the water was kept and he was drowned. Such situations where how to tell the parents your child is no more. So that was a very stressful situation in my practice. And this is another area which we feel recently, especially after I started my consultant that level. This a lot of incidents of psychosocial issues among children, especially in adolescents, we are facing after this COVID. And we, being pediatricians, every family approach us first before they go somewhere else. And we are not an expert in mental health, and we find it difficult to sort out these problems. And to add to this, we have got lack of there is a big dearth of mental health professionals who can handle children, especially in my area of practice. Sorry, I'm having. Then another issue comes, this is regarding some ethical issues like medical errors, especially when we are having something like a consultant practice. There are some very common issues in our practice where there are some accidental administration of drugs. Child can come with convulsions in the middle of the night and you are not able to tell what it is. This gives a lot of stress, maybe due to ethical issues. How to communicate these things to parents is a big problem which I have faced in my practice. There are certain very common drugs like domperidone. Domperidone syrup is there, drops is there. Syrup contains 1 milligram per ml and drop contains 10 milligram per ml. And accidental dispensing, accidental administration is very common with domperidone, and child coming to the casualty with extensor posturing and extra pyramidal reactions in the middle of the night is something which I have faced several times. Again, even paracetamol poisoning. Paracetamol comes in different strengths. It's such a common drug. These are all very common in our practice. And parental violence have become a big issue in practice now. And they are not bothered about the stress of the physician who is facing. About 3 weeks back, Kerala had that saddest moment when a casualty medical officer was brutally attacked in Tamarassery in Wayanad, following the death of a child with meningoencephalitis, which was not at all curable, and the doctor was attacked after 1 month of the death of the child. And that unfortunate doctor, he was not the person who has treated the patient, and unfortunately he was on duty in the casualty. You imagine the stress he had to have experienced in seeing the person who is coming to attack as well as after the attack, and the stress experienced by his colleagues in the hospital. That is also very important. And this is regarding coping. See, I had a very strange experience during my training in IMCH Calicut when a patient got angry with me and created a problem. And I was a bit worried. Next day, my morning, my professor called me and told, Jayaraman, it's not sufficient that you learn pediatrics. You have to learn how to handle patients, how to handle stress. You come with me, I will teach you. And then he told how was he handling stressful situations in his career. I'm referring to Dr. K.C. Rajagopal, who was my professor. Then he told me and advised me so much and how to cope up with these situations and how he used to do. So even those days, physicians used to think of these coping strategies and stress during practice. And I told him, I still remember what I told him. Sir, I am only 25. By the time I am your age, I am 52, I will be like you. That's all. So I think over the years, I have developed my own coping strategies to these stressful moments. And another issue which gives a lot of stress is poor patient outcomes, such as a failed newborn resuscitation. A child with cerebral palsy and mental retardation came to you for review who had been treated by you in the NICU. And you were managing the child immediately after birth. You feel you don't know whether you went wrong somewhere, which can give a lot of stress to a treating pediatrician. And these children can come with intractable seizures, and I think I used to be under a lot of stress on those situations. When I see a helpless head where I can understand that I'm helpless, where I cannot help them anyway.
2 ঘন্টা শোয়া পেন চেষ্টা করলি
Sorry. How does it affect your practice? It can influence your professional performance, sometimes leading to medical errors. And the important problems used to be burnout and emotional exhaustion, especially for the residents. It has become a big issue. Immediately after joining the residency, the pediatric residency used to be very demanding. And another problem is in repeated stresses give you a depersonalization sort of attitude and a compassion fatigue. These are all very common with pediatrics. And persistent stress can lead to cognitive impairment, sleep disturbances, and depending on the person and how to take it and how is his coping mechanisms, it may lead to substance disorders or even risk of suicide. And I was reading somewhere that premature retirement is very common among pediatricians, and it has become a very common problem in pediatric practice, or leaving the medical profession altogether, or leaving for some other non-clinical employment out of stress which are they experiencing during their clinical practice. And personal relationships also can be a casualty in these cases. Now, what are the coping strategies? These, I think I had been practicing for a long time in private with different levels. I worked in a tribal dispensary. I worked in a taluk hospital. I worked in a district hospital, and I worked in multiple levels of private practice all these years. So I think all of us will develop some strategies to come out of this stress over the years, because there is no organized structure or some organization like this to help or access to such organizations. So I think every physician will be having their own mechanisms as they grow up. And I think the best coping area will be our own family, and where we can discuss things and spend some quality time with your family, even though we physicians have got a very bad habit of being workaholics. And a good physician in our country is regarded as one who gives maximum time for his practice, who sees maximum number of patients. People are not bothered about what is a strain the doctor is experiencing. And we also fall into the trap as time goes on. So at least you have to see that you have to spend some time with your family, and you should areas where you can communicate. You can talk about your feelings. You can ventilate. You should have some friendship, some societies or some association memberships, either professional associations or the associations in the community. So networking forms a very good area. I think people are recognizing it more and more as the year passes. And the more you have friends, I think more than what I have felt is that more than from our profession, I think I will prefer to have friends from other professions also. It will help in decreasing the tension very often and involving their problems, their activities. So it will be better to involve in some voluntary activity as years go away. As Dr. Alfie was during the introduction, he was telling, we had been doing and we are still doing a lot in the field of prevention of adolescent suicides. And this is one way of bifurcating our somehow I think it was a good experience all through the way when we started that organization. And again, you should have a good communication skill. Now, I'm not talking about the parents or patients. That is a must in every practice. But I think in your work environment, I think you should be able to. I used to keep a rapport with my colleagues, and I think you should be able to communicate better. Communicate your problems with your colleagues, your professional colleagues. Let it be the doctors in the with you, and again in the NICU, the mainstay of the big person, every NICU revolves around the sisters working there, and we should have a very good rapport with them so that it may help to decrease your stress a little bit when you are managing your newborn children. And another thing which I had practiced in my practice is that when I started having an NICU and an NICU job, I made a team of about 3 or 4 doctors. In the end we had 4, and we had no patients under one particular person. We saw that every patient is under the team, and the team used to manage it. There was no my patient or your patient. Every patient was seen by all of us together at least once in a day. And when the parents were being addressed, we saw that all the 4 of us were sitting together and talking to the parents, And again, when a problem comes, it is easier to discuss with others and to reduce your tension. But of course, you have to come out of your I think personal ego and this thing. You should start working as a team. I think it reduces a lot of tension, especially when you are involved in critical care like in an ICU or a PICU. This has helped me a lot. Another important issue which I see in junior colleagues now is a work-life balance. There are more female physicians taking up pediatrics in recent years, and with over 75% of the pediatric residents now being women. This is a big shift which has come into the practice of pediatrics. Very few boys are taking up pediatric senior residency, and almost every other senior resident is a girl. And the demands of family life and extended working hours is posing a lot of significant challenges for them. And children's education and lack of adequate family support, everything gives a lot of concern for them, and they find it very often too difficult to meet with the stress of the workplace. There are a lot of financial issues of late, especially in India among pediatrics. I don't know whether how many pediatricians are there in the crowd, Pediatrics, I feel, is one of the most lowest paid specialties internationally. I was seeing a lot of papers from US even. They are one of the most underpaid specialty, I believe. And at least in India, at least in Kerala, at least, the pediatric postgraduates are paying a very low salary when they are fresh, And hospital managements are often reluctant to invest in pediatricians because it is not an income generating area. and there are not many procedures there, and the amount of income from the medicines or procedures or anything is very less compared to other specialties. So no hospital is interested in investing in pediatric practice. So very often it is one's own effort, and so understaffing becomes a big problem, and extended working hours are again adding to the strain. Unemployment has become a concern among junior pediatricians in Kerala. Many of them are being forced to take up jobs unrelated to their specialty, even in clerical jobs. Educational loans and EMIs are becoming a big issue in financial pressure, and making it is essential to include personal finance education in the medical curriculum. I may be telling something old, but I think a time has come where personal finance has to come into the medical curriculum, and how to live with how to go on your own. If the time is there, I will try some stressful situations which I came across. Arun, can I continue for another 10 minutes or 5 minutes?
Yes, Jayaraman, you have time.
Yes. This is a peculiar situation I had doing my practice. This is a 5-year-old girl who was admitted in my PICU, who had a very severe dengue, a dengue hemorrhagic fever, and dengue shock. And I had a very fresh junior with me at that time. Somehow she was very much behind that girl, that she was so much involved in the treatment of that girl. Even the bystanders were convinced that it's very difficult to save the child. But she was trying her level best. And one day I was away from the town. I had gone to Coimbatore for some work, and then I was coming, and I had a phone call from her. This girl is dead. And actually she was crying over the phone. Then I had to rush to the hospital. I told her, you don't go out of the PIC, you be there. I will come there. And then I went there, and my job was to console her rather than the parents of the child, because she was finding it so difficult to adapt to the situation where a 5-year-old girl was being so treated so passionately. I think she was much into that treatment, and she couldn't adjust with the death of the child. And it was a big shock to her. So this was a very stressful situation. And since we were working as a team, I could go there and I could pacify her, and somehow I packed her home at the middle of the night. Again, this is another dengue death. This is another problem which I faced as a consultant. This patient was referred from a hospital a little away from Palghat in a very critical condition. The child was misdiagnosed, and the professor of pediatrics who attached to that department happened to see that child. He was my senior in Madras for the MBBS. So then he sent it to me before he left the college in the evening. So this patient came to me, and the child was almost sure to die like that. A very sick situation, a dengue shock syndrome. And unfortunately, the treating physician had terribly missed the case. So what happened, I was in a big problem, an ethical dilemma. The parents are asking, what is the problem with the child? I know this is dengue. I have the diagnosis in front of me. I don't know how to communicate. It was one of the biggest stressful moments in my career. And I don't know how I sorted it out. Somehow I could send the patient after death without much problem. The amount of stress I faced with the correct diagnosis was overwhelming, because it was an ethical dilemma. These were 2 cases of snake bite which I had, very stressful situations. One child happened to me when I was working I worked for some time in government of Pondicherry in Mahi General Hospital. At the time I had this patient. This patient was a boy, about 10-year-old boy, who had gone for a marriage to a relative's house. He went to take a bath to the pond nearby, and he was bitten by a snake. He was brought with all symptoms of systemic envenomation. And I had no other go except to start anti-snake venom. What happened? This child developed a reaction to this ASV, which is quite common. Then I was between the devil and the deep sea. I don't know what to do. And I had to tell the patient, this patient is having parents that he is having some reaction. Then if I give ASV again, I don't know how they are going to react. But if I don't give ASV, I was sure this child is going to die. So then I took a bold decision, either to I'll take a chance. Let it, and I told them, anyhow, this is a very serious condition. I will try. And then, luckily for me, with the steroids and adrenaline on one side and ASV on the other side, I could salvage the life. And after everything, I was happy. Parents were happy. But the amount of stress I had in treating that patient, I think those days, ventilator and PICU were all not there. So, but somehow I was able to manage that child with severe systemic envenomation with a poisonous snake bite, who developed with an allergic reaction, not anaphylaxis, to ASV. Then another situation was a child was brought dead at 8 o'clock in a district hospital where I was on duty in the casualty. And this child, I was there, and my colleague who was a forensic surgeon was also there for something else. And we thought, anyhow, this child is dead. There's some wandering community, nomads, like, So we send the patient home, saying that there is no problem. Anyhow, the patient is no more. And so it's unfortunate for me. One old lady at that about 12 midnight told them that this child is not dead. Because in the snake bite, at times we used to have some muscle twitchings. She identified it as a sign of life, and she told them that this patient is alive. Then what happened? This child was taken to a nearby nursing home, and the junior doctor who was there tried all sort of resuscitations, and he told, "Sorry, you are a bit late. I could have said if you had come a little earlier." Then they were all agitated, and you imagine, I was in duty in the casualty. I was the only medical officer there, and a huge crowd of about 75 persons with the police came to attack me. They had even sticks with them. I was really in the government district hospital where I had to do casualty duties. I had a coping mechanism because it was always stressful. So before going for duty, I used to sit alone for about 10 minutes. I used to think that, I'm with any provocation, I'm going to get angry because I'm going to be in a government hospital casualty. I don't know what sort of people are coming. And at any time, I am at the receiving end. So this was my attitude. And I had I was very sure that I will not get angry with anybody during my duty. So that trick worked, Somehow I could manage to pacify them, and I managed to put the baby in the mortuary for a postmortem to decide the time of death. And I told them, if I am wrong, I am ready for any punishment. But I feel I was correct. Luckily, they accepted me, and I could manage with the help of the police. I put the baby in the mortuary, and next day postmortem was done, and I was saved, I believe. But the stress I had during that time was too much. Luckily for me, a physician, a senior physician who was on call came. I still remember his name. He had only 6 months to retire when Dr. Chandrasenan from Trivandrum. I told, "Sir, I am very stressed. I cannot take duty tonight. Can you take my duty?" Actually, he had no responsibility to take casualty duty. He helped me, and he told, "Jayaraman, you sleep, you relax." And he took my duty, and I was saved. I think my idea of not getting angry only saved me. That is my belief. So that was my coping mechanism. And but next day I decided I may not be able to continue long in government service, and that was the provocation for I leaving service in 2001. I think next day I sent my resignation letter. I never wanted to take any more stress. Not that I wanted to be in full-time private practice. So after that, I was in private practice from 2001 April. This is another very big issue. This is an NICU graduate. It is a big emotional trauma, especially because these tinies, as you imagine a child with 600 grams, we usually discharge them at 1,800 grams. We would have put them on ventilator, we would have put them on CPAP, we would have given so many artificial feeding, arterial, and so many things. We have taken so much of effort, and luckily the patient has survived and gone home. And they're coming back with a complication, and the patient dying is the biggest stressful moment in my life, and something which I found difficult to cope up with. But of course, I had to carry on. So somehow I had tried. Still, I remember a triplets. One of them died at birth. The other one the other two were with me for a long time. They went home, and the child was on artificial feed, because they had born very early, and some of with triplets and all, baby was on artificial feeds. Came back with necrotizing enterocolitis. Then I had to refer them to a tertiary hospital, underwent surgery, and following surgery, the child died. Luckily, the third one survived. And after this, we had to keep the third one again for care in my own nursery, because they were all upset. The family was upset, and they were with me for about 60 days, 65 days before that. So the amount of stress myself and my juniors as well as the sisters had, I still cannot forget, the stress we had. But maybe because we are having a team, we were able to continue. Again, there was one situation, is a doctor's driver's baby. This is another situation like the other dengue. She had, I don't know, somehow she was, this lady was an obstetrician. She did ultrasound, not a radiologist. She misdiagnosed the age of birth child, and the baby was delivered at before 8 months. Baby had respiratory distress syndrome and was referred to us. She was in the ICU with me. And unfortunately, the baby died. And I was in a situation, I don't know, they were asking me why the baby is premature, or why the baby should develop RDS. I was in an ethical dilemma, how to communicate. It was a big issue for me, and a lot of stress for me, how to communicate the illness and the cause and the situation to the parent, especially that parent happened to be the driver of the referring doctor also. So that was one of the stressful moments in my NICU career. And of course, as I told, somehow we were three, and somehow we could manage the situation. I don't know how I managed. So these are some situations which I had during my practice, and I think all pediatricians in this group would have had similar things, similar experiences, because these are peculiar to managing children, I believe, especially in a child with 500 gram or 600 gram or 700 gram, managing up to 1800 gram and discharging, and after 1 week or 2 weeks, they're coming back dead or with a serious illness which requires again critical care. These are all big stressful moments in my practice which I had experienced. But all said and done, I am very happy about pediatrics. I have never felt I have taken a wrong choice. With all this stress, I have enjoyed it. And in the end, I would like to say that every profession has its stressful moments. Maybe I am pediatrician, I am telling more about pediatrics. What matters is how we handle them and continue to grow in our work, developing our own coping strategies along the way. And I think we will develop it as the years go by. And life will never be a bed of roses for any physician, especially when the community demands more and more than what we can do to the community. And if I were given a second chance, I would still choose to live a life of a pediatrician, because I have really enjoyed the life. Despite all its stressful moments, I have truly enjoyed the life of a pediatrician, and I want to keep enjoying pediatrics for as long as I can. And I still see children and still try to help them whatever way I can. Thank you, Arun, for giving me this opportunity. Thank you, ASHA, for involving this very important field of helping the doctors in stress. And I will be definitely associating with you in my future professional life. Thank you so much.
So thank you so much, Jayaraman, for your lecture. We will invite questions to this. one of the issues that I did want to raise with you, Jayram, was, you've sort of highlighted the issue that professional stress is specialty specific. And there are specialty specific stresses. There are common stresses that doctors face, which is around interpersonal stress with colleagues. There's also stress around, with the hospital management. There is sometimes stress which happens because of rotas, on-call duties, work-life balance. But you have today highlighted the issues around professional stress, which is specialty specific. So over to my three colleagues, Alfred, Jimmy, and Shija, to look at any questions that we might have for you. Over to you, Alfred, Shija, and Jimmy.
Jayaraman, a very excellent presentation. And it is really it's very heartening to see how you overcome such stressful situations. My question is, you told that because of that incident and severe stress, you left government service. What is the difference? This sort of stressful situations can happen in private practice also. Similar or more?
Excuse me, I have worked in government setup for nearly 12 years, I believe, I worked in Government General Hospital, Mahi, and again, different levels in government practice, like a tribal dispensary, a taluk hospital, a district hospital. But I have felt that, I was under constant stress in government service. Because people expect a lot more, and because the number of patients, that is one thing which, because I talked mainly about pediatrics because, you wanted me to talk about pediatrician's view, and I thought I will go a little more specific with pediatrics, Like the number of patients we see in pediatrics in a government hospital is something beyond which you can manage, In a private practice, I'm seeing most of them with appointments at this stage. And I spend at least 10 to 15 minutes with my patient. I don't see many patients. I see with them appointments and I'm very happy. Where I can communicate to them everything well, and I am at leisure to think of. Even I can tell a patient when I'm not sure about my diagnosis, I tell them, look, you have a problem, I understand. And I will look up because I have not seen many such problems. I have to read a bit. You come after 2 days. And patients are very willing to accept. That is what I have seen in my practice. They have never thought that I am somebody who doesn't know. I used to accept it very freely. I don't remember. I have to look up. I will read my book and tell you day after tomorrow. I will try to sort out. This used to be my attitude, and I was very open. But in government practice, what happens, I had the chance of working in district hospital Palakkad as a single pediatrician, where you maybe already remember the person who was appointed to help me is one person whom we were all afraid during my first year, Dr. Jayaraman madam. She was an assistant surgeon in district hospital, and she was appointed to help me in pediatrics. So, madam, so we were managing pediatrics. So what happens, there will be a big queue. You imagine it's a district hospital, and at those times there is not many pediatric private hospital setup is there. And if you spend more than 2 minutes, the person standing behind is angry with me. He doesn't mind I spending 5 minutes with him, but he doesn't want me to spend 2 minutes, more than 2 minutes, the patient who is with me. A big problem. What I used to do during my practice, the presentation, I told them my single most good thing in my armamentarium is my eyes, Once my eyes are not there, I am a very poor pediatrician. What I used to do, I will just screen with my eyes. If something I feel bad, I put into the ward, The rest I will dispose. And I will see them in detail in the evening, going to the ward, But what happened, sisters don't want me to go in the evening and see patients, They feel I am upsetting their work, Or they feel that I am having some special interest. So I was not able to work freely in government service, to be very frank. And this was a nail in my coffin, I don't know how I escaped beating. There were almost 75 people coming with sticks and all. They shouted at me, "What the hell you are doing here?" But I had made my mind, I will not get angry at any cost. I don't know how I managed. Again, I had another, which since I was talking about pediatrics, I didn't tell you. The last incident was, I was taking duty in the casualty. A police officer came and told, I'm finding one person dead in the cell. Can you come and verify? I went there. There is one prisoner lying in this on the ground, dead. He had a lot of injuries on him. What I should do? There are another 3 prisoners in the cell. How can I write something which I have not done? So I escaped. I wrote, I found the patient dead in the casualty and the floor. Baby may be shifted to the mortuary to do postmortem and to decide the cause of death. And I came back. By the time in the evening, 4 o'clock, I'm getting a call from the local Manorama Daily regarding this death. I told, I don't know anything, you discuss with the superintendent. And I came back and switch on my TV, I was seeing there is a walkout in the assembly with cell death in Palakkad District Hospital. I thought I did the best thing. I didn't commit anything. And this case come to the court after about, I was called for I left government service, Then in 2012, the DSP, one vigilance DSP called me for inquiry regarding this cell death. You imagine 12 years have elapsed. So I was called for an inquiry after 12 years. Somehow I told him this is what happened, And then I was sent back. Then in the year 2019, just before COVID, this case came for in the district sessions court for what you call that was it was called for I'm not getting anyhow I was called as I was called as an expert witness. See, I'm appearing in the court after 18 years of the incident of a prisoner dying in the cell. I'm called to appear as an expert witness after 18 years. You imagine my situation. I'm still standing in the witness box. Since the accused are policemen, they had been stretching it, And what happened? That the lawyer appearing for them, he asked me, "Doctor, it is 19 years. How can you remember this? Do you think you are remembering?" Then suddenly it clicked me, He wanted to tell something that I'm not remembering exactly. Then it is a very easy way to escape. I told them this has not happened many times in my professional career. Only once it has happened. So till my death, I will be remembering this particular patient. I'm very sure about what I am written. But thank God I could understand the trap kept by the lawyer. So now I think you understand why I shifted. Why I never wanted that, that sort of practice.
അത് നിങ്ങള് വെള്ളല്ലേ കുടിച്ചില്ലേ, ചായ കുടിച്ചിട്ട് പോവാന്ന് പറഞ്ഞത്.
മ്യൂട്ട് ചെയ്യണേ വേറെ ആൾക്കാര്.
Okay, because it was always stressful.
You can mute from there, no?
Yes, I can. I have muted.
We can mute.
Yeah. Even I was doing it, but I couldn't find the.
There are a few questions, I think, Shrija. In the chat. Shrija, you're on mute.
Shrija, you're muted.
I think. Dr. Bashir has asked, I believe, is system failing us at government hospitals due to lack of everything, especially when we know what to do and it's not. Maybe that's correct, but somehow it is ultimately we are the people who have to face it and blame will fall on us, I felt I am confident to live without that. That's why I left.
Dr. Geeta Govindraj, madam,
has asked, how important do you think physical activity like jogging, working out, etc., is in reducing professional stress?
I think it's a good question, Dr. Geeta. I do agree, it is one way of letting out your stress, I believe. And I do fully agree with you.
Shija, I think Dr. Ananta Dave raised her hand to ask a question.
Yes, thank you. Thank you, Dr. Jayaraman. I've been following your talk with fascination, and I can relate to many of the insights because although I'm not a pediatrician, I did 2 training posts in pediatrics before specializing in psychiatry and child psychiatry. So many of the things that you've discussed around the emotional reactions when children are unwell and the feelings of parents, I can identify with. So thank you for being so open. I really agree with your point about the experiences being different for each specialty. But what I have also found is that in terms of coping mechanisms, it helps if we interact with doctors from all specialties because that helps us learn things about one another, share different ways of treating the situations that arise either in crises or in the course of our work, helps us to better understand each other's perspectives and develop those closer working relationships. Because I realized over the years, and I'm a practicing child and adolescent psychiatrist, and I realized over the years that most of the tricky questions that we come across, it's very difficult to find answers on our own. We need a team around us with different perspectives and experiences to find the answers. So just wanted to make that point and also wondered whether you feel that it is useful as a coping mechanism to come together with colleagues from other specialties. Thank you.
I think I fully agree with you, Dr. Ananta Dave, because coping mechanisms are required for any specialty. Let it be a psychiatrist. I'm seeing it day in and out. My wife being a pathologist, she also requires a lot of coping mechanisms, because. But I was telling this because I was asked to talk about pediatricians' view, and these situations are there everywhere. I believe like what Dr. Arun was telling, the problem with management, the lack of facilities, lack of staffing against duty hours, all these problems come with this thing. And management always expects you to do more and you are not provided with what you want. That's a big problem with corporate hospitals. And after some time, what happens, when a new person comes, you are being gradually sidelined. That again is a big stress for everybody in this corporate setup, I believe.
Thank you.
I think the grass always looks greener on the other side. We are surgeons. Me and Jimmy, we are plastic surgeons. And we always, actually, pediatrics from Government Medical College, Thrissur was one of the best postings, I think, which we used to enjoy a lot. But I never thought of pediatrics as a specialty of future because I couldn't stand the children crying or children suffering, because then itself it used to feel very stressful. But now as plastic surgeons, we all often have to deal with children with deformities. And it gives us a lot of happiness when you see the postoperative good results. But at the same time, unlike adult patients, this is also something which brings a lot of stress to us. Every day when we are dealing with pediatric patients, it adds an extra degree of stress to that day. So I can really understand how it must be to deal with this on a day-to-day basis. And it's a really kind of insightful to understand the other specialities also.
We have a pediatrician from the UK here. Sanjay, would you like to? He also has ways of coping with stress which are unique. Dr. Sanjay.
Yeah, thank you, Arun, and thank you, Dr. Jayaraman, for an excellent talk. And you've highlighted so many issues throughout your career and a really illustrious career as well. So I was really very, very interested to hear what you had to say about practice in India. So I'm practicing in the UK at the moment, and in fact, I'm retired now for the last 2 years as a pediatrician. And you mentioned something about retirement, and I know because we are very familiar with the Indian medical scene because we visit India very regularly, at least twice a year. And there is a whole work ethic among Indian doctors, which we probably would have had the same work ethic had we stayed on in India, which is that doctors don't retire in India. And it is seen as some kind of a professional failure to even take time off to have work-life balance. This is what we notice about our colleagues and our friends who are still practicing. They look at us and say, you're retiring, so.
Sanjay, you're muted.
Sorry about that. Sorry. I'll start again. So thank you so much, Arun, and thank you, Dr. Jayaraman, for an excellent talk. Really very, very inspiring looking at your illustrious career. So a few of the things that we practiced, I practiced the pediatrics in India for 3 years after I got my MD. So I'm familiar with some of the things that you have spoken about. Two incidents come to mind. One is that, we used to have this practice of drawing blood from the femoral vein because of the problems with venipuncture, as you very kindly highlighted. And on one occasion, this baby, and I was a junior resident at the time, developed a septic arthritis of the hip. And it was very, looking back now, yes, it was probably, I got the blood out, but obviously it's a complication of the procedure. And I know that this family came directly for me. There was no support available from the rest of the department, from my senior residents, from my chief resident, and definitely no support from the professors. So very much on my own as a new pediatric trainee. And I know that this family also tried to follow me. So I was really, really frightened that, they're going to corner me. And I shared this with my slightly more senior colleagues, and they reassured me that, it'll all be okay. So fortunately, that kind of didn't happen again. But the point you mentioned about pediatric death, that is so relevant even in the UK, because we don't come across pediatric deaths that often in the UK. So when it does happen, it is really very devastating for the pediatrician, for the team, as well as for everybody gets affected, and then you're managing the entire situation. Now, the way I think the specifics are different in the UK. Like, for example, I think we have a complaints procedure. So parents have a mechanism by which they can put in a complaint. There can be a serious incident inquiry. So all these mechanisms somehow channel the anger of the family, which doesn't then get directed to an individual consultant. I really, some of the harrowing descriptions that you gave about, people coming to you and kind of potentially attacking you with sticks. I had a similar experience. Thankfully, I wasn't attacked. I was working with my professor in my professor's private practice, and this was when I had just qualified. And this baby was brought into this nursing home, the professor's nursing home. I was the resident on call there, and the baby actually, was actually dead. So I, doing things according to the rules. And actually, just to kind of give a little bit of detail, when the baby was with us, the baby was actually alive. But when the baby went to the local government stroke private hospital, it was a KEM hospital, it was like a mixed hospital, the baby died there. And then they took the body away, and then they wanted a death certificate from me. So I said, I did not see the baby dead, so I cannot give you a death certificate. And the moment I said that, an army of about 40 to 50 people from the local slum, they came and started shouting and attacking this particular nursing home. So I rang my professor, and my professor said, oh, tell them to go away, or just don't let them in. And I said, hang on a minute, I'm like a junior pediatrician here. I really don't know how to deal with this situation. So finally, I told them, and it's the same, I suppose, skill that you were talking about, which is remain calm, don't get angry. And I think it is patient communication and human communication that in the end saves the day. So I rang the casualty officer in KEM hospital, and I just had to take their word for it and say, yes, you've seen this child dead. You have confirmed that the child is medically dead. because I had a different experience when I was doing a residency, when actually the child was certified dead and wasn't dead. They actually started breathing. It was a premature baby. So I was very, very wary of doing this by remote. But fortunately, I was able to give them a death certificate. I said, and the books may say what they say, but what you were saying, Dr. Jayaraman, was you have to use your judgment, think on your feet at the time and say, what is the best thing to do? So, I mean, after that, I left India, but I really hats off to people who practice in India with inadequate resources and I think also with inadequate support, because, your superintendents and your colleagues are, sometimes I find, and this may not be true for your practice, but the anecdotes that I've heard is that because you are in some kind of competition with people who are in private practice, you may not always get the support from your colleagues in private practice. So these are my few observations. In terms of stress and management, I mean, I don't know. I think some of the things that apply to the UK probably don't apply to India. But one thing that does apply is forming some kind of a group like this where people talk about stress. Because as you very rightly said, we have not been talking about stress. And this is true even in the UK. It's only the last 10 or 15 years, or maybe even less, 10 years, that we've been starting to acknowledge that as doctors, we need to talk about this stuff, because if you don't talk about it, and this is a personal admission from me, is that I myself did not acknowledge my stress, thinking or convincing myself that, oh, I don't get stressed, or when I do get stressed, I've got the ability to deal with it. And actually, that is not true. And most doctors I know have this kind of some kind of invincibility about them. They feel, oh, I'm okay. I'm not stressed. I can deal with this. I know how to deal with this. So I think I'll just and thank you, Dr. Arun, for giving me the opportunity to share my views. Thank you.
Thank you, Sanjay, for your words.
And one of the things Sanjay and his wife Shubhada do, I'll just bring Shubhada in for a minute, is that they are mindfulness practitioners and teachers. So they teach mindfulness to a lot of people, and there is Shubhada as well. Thank you.
Hello,
both.
everyone. Thank you.
Good to have you there.
Yes, thank you.
Jayaraman, was there anything else? Shija?
There's a question. Yes, sir.
Yeah, this
Dr. Sapna.
actually, Sanjay, I think I like this presentation by the words by Sanjay. I'm also reminded of those femoral punctures which we used to do we used to do something like 10 or 12 in a row during our training, and it was a very harrowing experience, to collect blood samples. Again, one thing I have trained and I have practiced in my practice all through the years where I was very active in my practice was any child who is dying, I made it a point that I will visit the bystander, I will visit the parents, and before they leave the hospital somehow, let it be any hour of the day, I made it a point. And if I had not met them, it used to give me a lot of stress, So at any hour of the day, one patient under my care is dying, I was there in the hospital to see them off from the hospital, and I have practiced it till all through the years I have practiced till up to 2020 perhaps. Thank you.
Dr. Sapna Nambiar has posted a query. Is there any way that we can learn from the mistake? Nothing seems to have changed for better over years. Why is it that despite knowing problems, no remedies are provided? And all that you said is there even today, shouldn't it be getting better?
See, that is a big problem, but our system has to evolve, I think in that way your step of this ASHA is a very good thing. And again, you will have your own coping mechanisms, like actually Dr. Sanjay was telling about jealousy among practitioners and all, Somehow I think at one stage, as years go by, you can develop a system where you have a team, and the team can cope up with it. And the other thing which I have felt is that you cannot wait for so many mistakes to correct it, So there is no time for you to wait for mistakes to happen. I think you have to start correcting it before it happens,
Any other questions, Shrija? I think.
Yeah, just one thing, Arun, if I may.
Of course,
Sanjay wanted to say something.
Sanjay, please.
Yeah, so no, I just wanted to say that this whole kind of field of physician well-being is very, very topical. And this is, I'm really pleased that, in India, with all the other difficulties that Indian physicians have to deal with, that there is a growing awareness that doctors need to find a way to look after themselves. And this doesn't mean, and in a community and in a country where selfless service is given such a high kind of hierarchical position, looking after yourself is seen as a very backward step. And I think that narrative, has to change. It has to change in the UK, it has to change in the US, and it has to change all over the world, because everywhere doctors are under a lot of stress and doctors are burning out. In the UK, the doctor burnout rate is about 40%. And this is among trainees and trainers. So 40% of the workforce that is kind of made a decision to follow a career to look after other human beings are stressed themselves. They're not able to perform. Dr. Jayaraman very rightly pointed out that your performance goes down. Your risk of making medical mistakes goes up significantly up. You're not, performing really well. So I think the thing that has helped is, first of all, talking about it, but also forming a community of doctors who consider this as a vital aspect of professional life. It's not simply about working less, I think, because even if you work part-time, you can be equally stressed. So it's about finding ways in which we can help each other, we can look after our own well-being, and also when these very, very stressful events take place, that we have some kind of a place that we can go to, like, some form of mentorship or some kind of a arrangement of that kind. But it's really encouraging to see that this conversation is beginning. And I think COVID may have accelerated it in India because there are some initiatives like Doctors for Doctors that has also come through, where people are starting to think about and talk about these things. It's very difficult to generalize what helps, but I've been working with a lecturer in pediatrics in South Africa, in Johannesburg, and we're looking at writing a paper on what kind of interventions would be helpful. And what they found through some of the work that's been done in Mayo Clinic in America and at Stanford is that organizational change is required. So just expecting doctors to look after themselves is not adequate. And that is going to be a big, like, at least if you can start with some kind of, corporate organizations and say, so what is this organization doing to promote doctors' well-being? What are the, policies in place? What happens if a doctor is stressed? What happens if they just had a death on the neonatal unit? How is that doctor going to cope? Is there an organizational level of intervention that is there? And what they found is that when this organizational level intervention is in place, you see that doctors' well-being indicators go up. So self-care is effective, but it's very subjective. And people think that, I go for a run every morning, so I'm looking after myself. But actually, when I'm at work, I'm stressed, I'm still not sleeping, and I'm maybe even having, sleeping pills. Workaholism is also a form of addiction. You're working as a way of dealing with the stress, because you're so frightened of not working, and so frightened of not being obsessive and not being a control freak. So all that, I think, plays into this whole business of, of course, I don't think we need any more studies to say that doctors are stressed or not. I think we need more kind of interventions to say what can we do about the problem, especially in a country like India, where the problems are so unique and so sometimes catastrophic, and I don't think the support systems are as effective as they are in some of the Western countries. Thank you.
Thank you, Sanjay.
Any comments about this organizational change which we need in casualties and acute care settings? Because that's very important. I think whenever you sit in the casualty as a pediatrician, obstetrician, or surgery specialist attending a trauma case, you are likely to be hit by an angry person around, because the only time when I felt secure and reassured was when I was a house surgeon on 1981, December 31st, when a group of people following an accident in Ernakulam Medical Trust Hospital, I was threatened and they said I'll be manhandled, a group of people. So the rule was there that you tell the secretary. I made a call. He said, use a lift. Our man is there. You will go to the room. You will not get out till I ask you to get out. That kind of support can be offered. I felt very comfortable, and they managed, because the administration thought that at midnight the doctor should be protected. But I must also say that never ever after that I felt any sense of security in any hospital. Latest was that when a patient was assaulting a resident, and I was also getting assaulted in Thrissur Medical College casualty, the attendant ran away. He apologized later, saying that I am not feeling very strong. So if I am hurt, then my family will suffer, he said. So this is the situation under which I can understand, Dr. Jayaraman, how, what shall I say, threatening it would have been to attend someone when everybody else is angry. And one more point is that all these people who come to pediatrics and general medicine in government hospitals, they are, what shall I say, they feel all adversities apart from illness in life. They are the only, this is the only place, and they know that they are going to get a bad deal. So they want to, identify you who is the soft target. So I think we have to really follow what Sanjay said. The organization should take the responsibility. And another thing is that the feminization, which Dr. Jayaraman had mentioned, this is happening. 70% of medical students are women. So all consultants, majority will be women, and there are other problems. So I think we need to do something organizational and systemic.
Shija, any further? Oh, Shubh, yes, Shubh. Yes, please.
Just to suggest another point, also, I think if every doctor has some kind of a mentor or a colleague or somebody who they can talk to, and, generally, as we are training as well, to normalize, that, stress is okay. Everybody gets stressed, but there are ways of coping, there are ways of handling, there are ways of, talking to your colleagues, getting second opinion, involving other people, like Dr. Jayaraman rightly said, when you're working in a team, you're somehow stronger with numbers, and you make a joint decision. And there are so many, we come across so many difficult cases, where, there's no right or wrong sometimes. It's just, what decision do you make and how do you proceed? And, when you have support from other senior doctors with you, I think it's so much more easier to do that, to stand by whatever decision you made, to talk to families, and everybody's sort of singing from the same hymn sheet. And I think, that needs to be encouraged more. Whereas I think we practiced in India for 3 years, and I found it really isolating because sitting in my own clinic, I've trained as a general physician, I did MD medicine. So, and, I hadn't got enough experience by the time I finished MD, and, sitting there and having all these people come in with all sorts of illnesses and with no money and not able to investigate them. It was really difficult. How do you really manage? So I think, having that kind of support is really useful. And also, explaining to juniors that, okay, you're stressed, talk about it, let's, discuss it. There are ways of managing, coping, dealing with things. You don't have to sit in a corner and get stressed by yourself. We all are in the same boat, really. Yeah. So mentorship, I think, really useful. Yeah. Thank you.
Thank you, Shubha. Shija, is there anything else that we...
Dr. Ina has raised her hand.
Oh, Lena, yes.
Dr. Lena.
Dr. Lena?
Hello.
Dr. Lena, did you have a question?
Sir, not a question, sir. Just some comments from my side. Thank you for this. Thank you for organizing this talk by Dr. Jayaraman. It was so relatable. I could actually visualize whatever sir was telling, sir. Sir, I'm audible, sir?
Yes, we can hear you.
Yes, sir. Dr. Jairam's talk was very, very relatable, and I could really visualize like every scenario that he was explaining. It was a very lucid talk and very nice talk. One thing which I thought was strikingly standing out in sir's presentation is how at every point his mentor stood with him, sir's guide stood with him, and how sir stood for that intern who was going through a stressful phase when she was dealing with that 5-year-old child in the ICU. So that kind of a support system is something which I think is lacking in the present system, sir. That support from the seniors, support from the colleagues, that is something I feel is lacking in our present medical system. So maybe one way of that is this mentor-mentee program, but otherwise also that brotherhood and improving our fraternity, standing up for each other also is something I think we need to be focusing on other than self-care. I think as a community also, I think we should stand up for each other. I just wanted to put across this, sir.
Thank you, Lena.
Thank you, sir.
Okay, I think we're getting to the end of our somebody else put in a comment just now. Somebody called Tico has put in a comment. Okay. Should we wind up the session then? We have it for 90 minutes now. Shija, would you like to just wind it up?
Oh, yes, sir. On behalf of the team ASHA, we extend our sincere thanks to Dr. Jayaraman, sir, for his deeply reflective and compassionate talk on professional stress. Sir, your insights brought to light the emotional challenges that many of us are silently carrying across all specialities. And your perspective added immense value to our collective understanding of stress in medical practice across all specialities. So next, a warm thank you to our chair, Arun Kishore sir, for guiding the proceedings very smoothly, and to the entire ASHA team for the tireless efforts in organizing yet another very meaningful webinar on behalf of ASHA. And last but not the least, I express my sincere gratitude to all our attendees and participants. Your active engagement and thoughtful inputs have truly enriched today's conversation. So once again, thank you all, and let us continue to support each other along this professional journey with ASHA. Thank you all, and a very good night to all of you.
Thank you. Thank you.
Thank you.
Thank you.